Good day. I am Dr. Daet. I will be discussing to you the cardiovascular and the peripheral vascular system. I am optimistic that you will love anything related to the heart. The objectives of this is to let you know on what to ask, on what to feel, and what to hear in a patient with a possible cardiovascular problem. In order for you to arrive at the logical diagnosis, because a thorough history and PE can minimize diagnostic errors. Okay, so let's start with the anatomy of the heart. The heart is located within the thoracic cavity, medially between the lungs in the mediastinum.
So this is the precordium. As you can see, it's from second intercostal space to the fifth intercostal space. This is the right parasternal line and the left midclavicular line. Okay, so you have to locate also the angle of Louis. Okay, so where you can feel the bony ridge. Okay, once you have to locate first the suprasternal notch, and then a few centimeters will be able to palpate the ridge, and the attached to that is the second rib. So below that is the second intercostal space. So third rib, third intercostal space, fourth rib, fourth intercostal space, fifth rib, fifth intercostal space. So this is useful in localizing your problem and murmurs. Okay, so we have to learn the base. Base is from here, the superior part of the heart. Second intercostal space, parasternal line. So it can be right and left parasternal line. Okay, for the apex, it's located here, fifth intercostal space, within 1 to 2 centimeter medial to left midclavicular line, and then the fifth left intercostal space within 7 to 9 centimeter lateral to the midsternal line. So I have to also learn about the borders of the heart. Right border, upper border of third costal cartilage, 2 centimeter lateral junction, up to the 6th right costochondral junction. The inferior border, 6 to the 5th left intercostal space, and this is formed by the right ventricle. And the left border is apex up to the second intercostal, second left costal cartilage, 1 to 2 centimeter from left of its articulation. This is formed by the left ventricle and the LA superiorly. So you also need to know the clinical valvular areas. So close to the heart, these are valvular areas, so you can appreciate the murmur. Okay, this is for the second intercostal space, right parasternal line. One you can appreciate is the murmur of the aortic valve, either aortic stenosis or aortic regurgitation. Okay, here is for the second intercostal space, left parasternal line. One valve you need to appreciate is the valve, so you will be able to appreciate the murmurs of pulmonic stenosis and pulmonic regurgitation. Okay, on this is the fourth, fifth intercostal space. You can appreciate the murmurs related to the tricuspid valve, either tricuspid stenosis or tricuspid regurgitation. Here, last part is the fifth intercostal space, which can you can appreciate the murmurs related to the mitral valve. It could be mitral valve prolapse, mitral stenosis, mitral regurgitation. Okay, so this is the cardiac cycle. So checks for your heartbeat from other to other, and then we'll just concentrate on the heart sounds on the bottom part of the cardiac cycle. Okay, remember that there is a systole and diastole. Diastole is during the relaxation of the heart. Systole is during the contraction of the heart. Okay, so systole starts on the first heart sound. Diastole starts on the second heart sound. Okay, and the first phase in the systole is the isovolumic contraction phase, wherein there is just a contraction, but there's no change in volumes. Hence the term the isovolumetric or isovolumic phase. It's the same. Okay, ejection phase, when the aortic and pulmonic valve opens. This is during the start of ejection. This is the rapid ejection phase. After the rapid ejection, there will be a reduced ejection. Okay, volumic contraction phase and the ejection phase. Okay, for the diastole, uh, it always starts in the closure of the semilunar valves, the aortic and the pulmonic valve. Okay, for the systole, it is a subvolumic contraction phase. For the diastole, the isovolumic relaxation phase. Okay, so same thing, there's no change in volume. The next phase is the feeling phase, where you can appreciate the third heart sound. Okay, so we call it the ventricular feeling gallop. So this can be a normal finding, but when there is a heart failure or LB is dilated, you can appreciate the third heart sound. Okay, fourth heart sound is represents the atrial contraction, and this is a almost pathologic. It means that the atrium is contracting to the stiff ventricles. There's a decreased LB compliance. So this can be appreciated in patient with LBH, elderly. Okay. Okay, so we'll proceed with the symptoms. Okay, symptoms: chest pain, palpitation, shortness of breath, or edema. Chest pain can be cardiac, pulmonary, or extrathoracic etiology. So just near the heart, pericardium, aorta, trachea, large bronchus, parietal pleura, chest wall. So you can also include the skin, muscle, bones, and sometimes extrathoracic structures can also be included: gallbladder, stomach, the neck, and which can be called as a referred pain. Sometimes here you can see some patient on the esophagus to GERD. Okay? So with at the base, there's a causes of chest pain. Okay, so the angina, myocardial infarction, pericarditis, aortic dissection. Pulmonary can also cause chest pain, GI disorders, GERD, diffuse, even anxiety can also cause chest pain. But you have to know the location, the quality of the pain, if it is pressing, knife-like, ripping, the severity, timing, factors that aggravate, especially if it is aggravated by exertion. Likely you would think of possible angina pectoris. Factors that relieve and the associated symptoms. Okay, so the angina pectoris is myocardial infarction. Ischemia, there's just a build-up of cholesterol at the blood vessel. In comparison with patient with myocardial infarction, you can see that the patient is a totally occluded coronary artery or sudden occlusion because of the thrombus formation. Okay, so same quality, same location, but the problem with it is the severity and the timing. Most of the time in a patient with the angina, shorter time duration, but in patient with myocardial infarction, the timing is prolonged. Okay, so factors that aggravate, MI not always triggered by exertion, and that relieve the MI usually is not relieved by the rest. Okay, so almost the same, but commonly in patient with myocardial infarction, they have a associated diaphoresis. For the pericarditis, this is due to inflammation of the pericardium, and the common description of it is the patient has sharp knife-like kind of chest pain. Unique thing about the pericarditis, this is aggravated by lying down and sometimes with the deep breathing, and it is relieved by sitting or leaning forward. That is typical in patient with pericarditis. In patient with aortic dissection, there is a tear in the aortic wall causing a dissection of the media. Okay, so this is usually described as a ripping or tearing in character and radiating to the neck, back, or abdomen. Okay, so they can have associated complications, which include here, if there is involvement of the arch of aorta, it can affect the left recurrent laryngeal nerve, which cause hoarseness. If it involves the brachiocephalic trunk, it can cause hemiplegia. And in patient, if it involves the about descending part of aorta, the thoracic part, can affect the artery supplying the spinal cord, thereby causing a paraplegia. Okay. So for the next one is the palpitation. This is unpleasant awareness of the heartbeat. If the patient has a premature ventricular contractions, then the patient can have a transient skips and flip-flops. If the patient has a rapid regular breathing from normal and then has rapid regular breathing, you would think of a paroxysmal supraventricular tachycardia. Okay, so shortness of breath can be reported as dyspnea, which is an uncomfortable awareness of breathing, or topnia if the patient has a difficulty on breathing on lying position and prefers a sitting position. This is the orthopnic position. If the patient is a paroxysmal nocturnal dyspnea, this patient awakens patient from sleep usually 1 to 2 hours after going. So usually because there is a redistribution of the fluid into the lungs. Okay, so these are the causes of dyspnea. It can be heart, bronchitis, asthma. Most of the time is on lung problem. But we'll focus more on the left-sided heart failure, which can be LV or the mitral stenosis. If you review the flow of the blood, there's problem with the mitral valve. There will be a backflow of blood into the pulmonary circulation, thereby manifesting as a difficulty of breathing. No? So there will be a transudation, stiffness of the lungs, and there will be an increased work of breathing. Okay, so you have to look for the timing, factors that aggravate, relieve, and what is the setting, and it can help you the diagnosis of the patient. Okay, for next is for the edema. This is excessive accumulation of fluids, usually appreciated at the lower extremities. It could be heart failure, high pulse, kidney problem, liver problem, or a positional problem. Okay, so for examination techniques, here you can see in the skin, patient is a cyanosis, patient jaundice, or patient is cyanotic. Okay, for the eyes, you have to look for possible jaundice. This could be a sign of advanced heart failure. Patient here is central asthma, which can be a sign of lipid disorder, or patient with a subconjunctival hemorrhage can be a sign of atherosclerosis. You can see this is a sign of a central cyanosis. So these are the causes of the central cyanosis. Most common is the tetralogy of Fallot. You can see this is the blood circulation. Since the patient has pulmonary stenosis and there is a ventricular septal defect, the deoxygenated blood is mixed with the oxygenated part of the heart, so there will be a cyanosis in the patient. So this is my mnemonics, tough probe. It's a tough problem. P for pulmonary stenosis, R for RBH, O overriding aorta, and BP for the ventricular septal defect. Okay, so for the hands and fingers, you can see the fluid discoloration of the extremities. There's peripheral cyanosis, what we call acrocyanosis, is due to a lower flow of the extremities. Okay, for the non-tender, slightly raised hemorrhages in the palms. This is what you call Janeway lesions. And for patients with the tender raised nodules in the pads of fingers, this is what you call the Oster's nose. And this one is the linear petechiae in the mid position of the nail bed. This is what you call the splinter hemorrhages. This three, Janeway, Osler's, and splinter hemorrhages are all signs of telltale signs of the infected myocarditis. Here is the what you call digital clubbing. Clubbing is which is described as spoon-shaped nose and can be secondary to cyanotic heart disease and infective endocarditis. To check is you have to do the Shamroth sign like this, and if there is a loss of diamond-shaped window, that is diagnostic of presence of clubbing in the patient. Here is abnormality. There is an opposable finger as time, which is frequently associated with atrial septal defect. It is also associated with Holt-Oram syndrome. Okay, there is a unusually long and slender fingers. We call it the arachnodactyly, or spider fingers. This is in patient with Marfan syndrome. And you can do the following: the wrist sign, thumb sign, no? And this is the problem with the Marfan syndrome, is the risk of mitral valve collapse and aortic aneurysm. For the feet, patient has cyanosis and prominent clubbing toes compared with the fingers. This is what you call the differential cyanosis. The differential cyanosis, the bluish discoloration of the lower extremity but not the upper extremity, and it is usually present in a patient with a PDA with a reversal of shunting. As you know, the PDA is connection from the pulmonary artery to the descending aorta. So since there is a higher pressure uh, at the aorta, the flow normally is from the left to the right side of the heart, which is the pulmonary trunk. Okay, so if there is a chronic flow on the right side of the heart, there will be a increased pressure and cause pulmonary vascular diseases. So if it is not repaired, there will be a problem on the pulmonary artery circulation. So pressure on the right side will increase to the point it will exceed the pressure of the left side, the aorta. No? So there will be a reversal of shunting. So there will be a preferential flow to the lower extremities since it's located at the descending part of the aorta. As you know that the arch of aorta branches, do you remember the branches? Just remember these mnemonics: A, B, C's. A for arch of aorta, B, this one is the brachiocephalic tract, C for the common carotid, the left common carotid, and S for subclavian artery. So this applies on more on the upper part of the body. Okay, so how about this one? An untender is likely raised hemorrhages of the soles. No, this is also a Janeway lesion, same with the hands. And this one is then the raised nodules, palsitos, Osler's nose. Okay, so if you have those signs, you have to look for the check for possible infected endocarditis. For the blood pressure, just to tell you that the 120 over 80 is already considered as elevated, and patient with a 130 over 80 is already at stage 1 hypertension. So stage 2 hypertension if your BP is 140/90 and above. So just need to avoid those things. Have a cell phone, no support of the arms. Okay, for the heart rate, so we have to check it in the apex area. Normally it's 60 to 100, and then you have to determine if it is regular or irregular. Normally it should be regular rhythm. No, if it is irregular, you can say it is sporadic, regularly irregular, or irregularly irregular. Okay, so sporadic means there's just skip beats on those areas. Premature atrial contraction, PBCs. If you say it is regularly irregular, this is a regular occurrence of the skip beat, like this one. It occurs every 3 beats. So this is also a example of regularly irregular. In patient with a atrial fibrillation, an atrial flutter, they can have a regularly irregular rhythm. Okay, so that's for the jugular veins. This is the anatomy. The subclavian vein branches to external jugular vein. This one is the internal jugular vein. So internal jugular vein is just beneath the sternocleidomastoid muscle, and the external jugular vein is above the sternocleidomastoid muscle. This is another drawing. Internal jugular vein, and this is the external jugular vein. Clinically, you can see in here, this is the line of the internal jugular vein, and you can see here is the external jugular vein. Okay, the muscles, you can see here is the external head of sternocleidomastoid muscle. This is the clavicular head. Also within the square is the location of the internal jugular vein. So that's the where pulse of IJ is prominent. Okay, so we have to determine also the preference between internal jugular pulsations and carotid pulsations. As you know, the IJ is a pain, it's rarely palpable, but patient with the for the carotid it is palpable. As you can see, it can be palpated at the lower part of the neck immediately. Okay, so for the quality, this is soft, rapid, and undulating quality, and it has a two elevation and two troughs. Okay, so for the carotid pulsations, there's a vigorous thrust with a single outward component. Usually, it's as high as 40 to 45 millimeters mercury. Okay, so for the it can be obliterated at the part of the if you press if for the carotid artery these pulsations are not eliminated by pressure. Okay, how about change with the position? No? The IJE can change with the position while carotid does not. No? Okay, for at times if the patient is a hypervolemic or patient is congested, you need to adjust the angulation of the bed. As you can see, if the patient is hypovolemic or septic, you have to advise the patient to lie flat more. If you cannot see the jugular vein, just say that the jugular vein pressure noted. Okay, but there is you have to report like this. The ABP is 4 centimeter above the sternal angle with the bed elevated to 60-degree angle. But if you want to get the the central venous pressure, you had to add 5. No? This is to the towards the right atrium, which is constant. No? So, for example, the JBP is 4 centimeter water, so you add 5 centimeter, so it's 9 centimeter water. Okay, so you have to put the ruler at the sternal area and then ruler at the highest point of pulsation. So usually if the JBP is more than 3 centimeter above sternal angle or more than 8 cm, so you add 5. So more than 8 cm, it's considered elevated or abnormal. Okay, for the causes of elevated JBP, this is obvious. Just know the anatomy. If you have problem here, right ventricle, problem with right cuspid valve, if you have a constriction here because of the mass of superior vena cava, or there is a constricted pericarditis, meaning the covering of the heart is already scarred, so there will be a decreased flow, RV inflow, so there will be a jugular vein distension. Okay, so usually it descends during the inspiration, but if does not or there is a rise of the JBP, we call it the Casmo sign. So usually this is associated with constrictive pericarditis, restrictive cardiomyopathy, and others. Okay. For the JBP waveforms, I have to also check for this. There are three waves: A wave, C wave, and then the V wave. And there are two descents: the X descent and then the Y descent. So A wave stands for atrial contraction. So while tricuspid valve opens, and these are example of abnormal A waves. If there's a prominent A waves, if we think of resistance to right atrial contraction, which is the tricuspid stenosis, or patient has a hypertrophic right ventricle, like in patient with pulmonary hypertension. Canon A waves is a course when there is a contraction against closed ventricle, like in patient with a third degree AV block or in patient with ventricular tachycardia. These are dysynchrony between the atrium and the ventricle. Absent airways, so this is obvious in a patient with the atrial fibrillation. Okay, C stands for the ventricular contraction. So it's specifically the isovolemic contraction phase wherein there's not no flow yet. Uh, uh, it can happen in patient with the giant CP waves and have a patient with a severe tricuspid regurgitation. Okay. So X descent, this is during the time the atrium relaxes, and then there's a tricuspid. So X stands for relaxation, so atrial relaxation. So obviously in patients with severe tricuspid regurgitation, this is absent X descent, but it's not reported on physical examination. So significant that if there's large P waves, this is seen in patients with a tricuspid regurgitation. As you know, there's V for vertical filling from the veins. So there is it can be elevated in patients with a tricuspid regurgitation. Why descent is the when atrium empties while the tricuspid opens. So there is a obstruction to RV inflow, like for a patient with tricuspid stenosis, of there is excessive fluid accumulation at the pericardium, and patient with tamponade, there will be a compression of right ventricular inflow. So the Y descent will be prolonged or lengthened. That is for the KBP waveforms. Okay, so now we'll proceed to the carotid artery. Say the carotid upstrokes are brisk without using example, but for our institution, we also added the AREC. It stands for the A for amplitude, R for regularity, E for equality, if there is an equal pulse, and the consistency of the wall, if it is soft or rigid, because it can suggest also a possible carotid artery disease. Okay, so for this, you assess the quality of the carotid upstroke, its amplitude and contour, and for patient, you need, especially in elderly who have a stroke, you have to listen before you palpate. So usually it should be in here, not there, no? So it's near the upper. But some book would say you have to auscultate 3 parts of the carotid artery. But idea is they say it's at the angle of the jaw because most common obstruction carotid artery is at the bifurcation. Okay, so for the quality, you have to make sure the patient in supine position, bed elevated at 30 degrees, and then note for carotid pulsation, you can use the index or middle finger or the uh, thumb. Okay, this is the normal contour, should be smooth and round. Usually the peak pulse pressure is about 45 to 50 millimeters mercury. Amplitude is strong, contours brisk, and then usually it follows S1 almost immediately. So significance of this is this carotid artery pulsation. You can use it to determine as a basis for the murmur you hear is systolic or diastolic and or because if it coincides with the carotid artery pulsation, it means that the murmur is more on a systolic kind of murmur. Okay, sometimes we will have a small weak pulse in patients, especially with heart failure, hypovolemia, severe AS, or patient is on hold. So there's a specific pulse for patient with the aortic stenosis. We call it pulsus parvus et tardus, meaning there's a weak and delayed pulse. It means that the peak is delayed and usually close to the second heart sound. So this defines a severe aortic stenosis. Okay, for the large bounding pulse, this is increased to strong and bounding. It can be seen in a patient has fever, anemia, hyperthyroidism, AR, aortic regurgitation, PDA, or patient with heavy fistulas. So there's a classic example is the patient with a chronic severe aortic regurgitation, wherein we call it Corrigan spas, described as a sharp rise and rapid fall off. But sometimes patient can have bifid or Besperian pulse, but they say it is a rare occurrence. Okay, Besperian pulse, it means there is a double systolic peak and can be seen in pure AR, combined ASAR, hypertrophic cardiomyopathy. These are the other example. This is for aortic regurgitation, and this one is for patient with hypertrophic cardiomyopathy where there is a slow rise of the second peak. Okay, for pulses alternance, this is a alternating strong and weak beats, which is present in patients with left ventricular failure and usually accompanied by the left-sided S3. Bigeminal pulse, this occurs in a patient with a premature contractions, which occurs every other beat is normal, abnormal, normal, abnormal, normal, abnormal. This is PBCs and bigeminal. Patient for there is a variation and respiratory breathing. No, this is there is a decrease in the pulse amplitude on quiet inspiration. No, this is a paradoxical pulse. But if this is less pronounced, blood pressure cuff is needed. No? So this is for uh, patient.
First Korsakoff sound that will appear, then disappear during inspiration.
Okay. This is the patient manometer.
Next, slowly listen for when the first Korsakoff sound no longer disappears with inspiration.
Okay, so you have to watch the patient at the back so while looking at the blood pressure, and you have to, as you know, if there is chest rise there's an inspiration. So most commonly the paradoxical pulse are seen in patients with pericardial tamponade, but it can be also present to other disease entity. So first correct sound that appear and disappear during inspiration, and then get the first correct sound that no longer will disappear during inspiration. So the difference 26, and it is more than 10 to 12, and this is positive
First,
for paradoxical pulse. Okay, so as you palpate the carotid artery, you have to check also presence of vibrations, trills. No, trills is more on patient with a cardiac murmur. Carotid artery disease, you have to check for the presence of bruit. So the presence of bruit is high, most of the time is due to carotid artery disease, but it can also be due to fortuitous carotid artery, external carotid arterial disease, AS, hypervascular arterial hyperthyroidism, and external compression from thoracic outlet syndrome. So already finished with the carotid artery. Proceed with the inspection and palpation of precordium. This is an example of findings. Dynamic precordium, the PMI is stopping 1 centimeter lateral to midpoint in the 15th, and that is the normal finding. This one is dynamic precordium, PMI is diffuse, 3 centimeter in diameter, palpated and the anterior ciliary line, the 5th and 6th intercostal space. This is normal. So, are we now? So this is the sequence of the cardiac examination. Supine with head elevated 30, left lateral, supine with head elevated. So we already finished with the examination of JBP, carotid pulse. Next, for inspection palpations, you have to do this one: inspect and palpate the recording. So I taught you about the valvular areas, second right, left and third phase, RP and LP, including apical pulse and diameter. So for the palpation of pulse, and take note if there's thrill, this is a palpable heart murmur, felt the shudder under the hand, and best felt with the distal palm. If you try to appreciate the trust movement of sustained movement of the ventricles, this is what we call heat. This can be appreciated in the on this part of the hand. Okay, so remember again, the right second interspace, left second interspace, the left sternal border for tricuspid, and then the apex LV area. Okay, so on inspection, this is normal. Patient can have a flat chest, but if there is a depression, we call it a rectus excavatum. So also take note of presence of this one, midline sternotomy, or this one also. There's also midline sternotomy, and this one bulging at the subclavicular area. This is a presence of permanent pacemaker. So you have to be aware of those things in patient. So if it is abnormally protruded at the center, you think of the pectus carinatum. Okay, so for the that precordial area, well, it's the precordial bulging, and so this is in patients with congenital heart disease, with LV enlargement acquired during the childhood. Okay, this is for the inspection. You have to check if there are any abnormalities. Okay. So for the uh, description of the precardium, to palpate your hand and then localize it. Initially, you have to see, palpate. If it's apex beat is not visible but may or may not be palpable, this is as described as a dynamic precordium. If the apex beat is visible and palpable but normal in size and amplitude, that is dynamic precordium. If it is hyperdynamic, increased diameter, amplitude of the apex beat is associated with rocking movement or heave of the precordium. This is already considered as a hyperdynamic. Now, so what the question is what is the normal in size and amplitude? Okay, so this is the description of a normal apex beat. Usually at the fifth, but occasionally it can be at the fourth intercostal space. The 1 to 2 centimeters medial to the left make 7 to 9. So you have always remember 1, 2, 7, 9 centimeters for the mid-sternal line. Diameter is discrete, so usually it's less than 2 centimeters. So if you able to see an apex beat that's visible on 2 intercostal space, you have to think that the apex beat is hyperdynamic. Amplitude is usually brisk and tapping character, and the duration is less than 2/3 of the systole. So this is differential diagnosis in patient with a problem on the LB impulse. Okay, either normal, hyperkinetic, there's a pressure overload, or there's a volume overload. If you review the effect of pressure overload, there is a it can result to concentric hypertrophy, as you consider is a reduced ventricular volume. Okay, in a patient with a volume overload, that can result eccentric. The diameter is enlarged and thin. So compared with a patient with a normal cavity. Okay, so hyperkinetic can be due to anxiety, hyperthyroidism, severe anemia, or fever, or in pain, or in patient or hyperthyroidism. This can cause a hyperkinetic states. No, okay. So apical impulse may be displaced upward and to the left by pregnancy or a high left diaphragm. Okay, so lateral displacement may be due to the following. Okay, so cardiomyopathy, ischemic heart disease, and intestinal shift. If it's the apex beat is on the right, they call it dextrocardia. Situs inversus is the term if the heart, stomach, and liver are on the opposite side from normal. right-sided heart with a normally placed liver and stomach is usually associated with a congenital heart disease. Okay, this is patient for an hyperkinetic states. No, diameter is about 2 centimeter, but their make diameter feel larger, and duration is okay, normal. Amplitude is more forceful tapping. In patient with a aortic stenosis, the diameter is more than 2 centimeter, more forceful, but there is a sustained duration and extend up to the S2. In patient with a volume dependent cardiomyopathies like this one in patient with a aortic regurgitation, mitral regurgitation, or dilated cardiomyopathy. Most of the time, the amplitude is of diffuse and often slightly sustained. But the difference in patient with a dilated cardiomyopathy, can you see this one? Okay, so they can have a hypokinetic states. You can see in here for hyperkinetic states, sustained, or impatient by hypokinetic states. So uh, sustained or high amplitude impulse, but there's a normal location of apex speed. There is LPH from pressure overload. Example of the pressure overload is from patient with aortic stenosis and a patient with a chronic hypertension. Sustained high amplitude impulse but displaced laterally means that the heart is enlarged. This can be due to volume overload. The volume overload consists of the mitral regurgitation or aortic regurgitation. Okay, there is a sustained low amplitude, no, and there's a what you call hypokinetic impulse. You would think of a dilated cardiomyopathy. Means that the heart is large and the muscle is thinned out because of certain causes like ischemic heart disease or due to viral cause. Okay, on palpation, you can also appreciate the presence of uh, palpable brief metastatic impulse, which indicates an S3. Remember again, the S3 is due to rapid early filling phase. No, in patient with a congestive heart failure, or in patient with a palpable S4. No, this is due to stiffness of the left ventricle. So it can be in patient with aortic stenosis or in patient who are elderly. Okay, that is can be appreciated on the apex area. How about this one? This is for patients with a possible right ventricular. You can appreciate a impulse on those areas. You think of a possible right ventricular in origin. Okay, so just like on the left, it can be hyperkinetic, secondary to pressure overload and volume overload. So, another example for pressure overload is pulmonary stenosis and pulmonary hypertension in patient with volume overload secondary to atrial septal defect. Okay, so you can see there the pressure duration is sustained, so there's both a double S. And for volume overload, usually is normally to slightly sustain. No? So, but you can see there's a markedly more forceful in patient with the volume overload. Okay. So marked increase in the amplitude with little or no change in duration of volume overload of right ventricle, you think of a atrial septal defect. But if the impulse with increased amplitude and duration, no, you have to think of pressure overload. So duration, sustain, pressure. No? So pressure, pulmonary stenosis, and pulmonary hypertension. So that's fine. Well, how about in the left second intercostal space? If there is a prominent pulsation, you have to think of possible increased pulmonary flow in the pulmonary artery. If there is a palpable S2, that is suggestive of increased pressure on the pulmonary artery. How about here at the right second intercostal space? If there is a palpable S2, this is suggestive of systemic hypertension. If there is abnormal pulsation, you have to think of possible dilated or aneurysmal aorta. No? Okay. Trills may accompany loud, harsh, or rumbling murmurs. Example is the aortic stenosis, PDA, BSD, and MS. So trills are palpated more easily in patients in a position that accentuates that murmur. So same thing, trills are best appreciated the distal part of the palm, while the hip is best appreciated at the base of the palm. Okay, so this is how to check, no, for the hips, for the trills. So in here you can try to appreciate the presence of hip of the right ventricle. Here you can try to appreciate first the apex beat impulse, and then you can shift the position at the left lateral decubitus position, especially in patients with mitral stenosis. Okay, so percussion. Palpation has replaced percussion in estimating the cardiac size. If you cannot palpate the apical impulse, maybe the percussion is your only option, but it has a limited correlation. So start with the towards the cardiac tunnels in the third, fourth, fifth intercostals, and possibly the sixth intercostal. If the patient with markedly dilated failing heart, they may have a hypokinetic apical impulses placed part, but the patient with large pericardial effusion may make the impulse undetectable. Okay, for the auscultation of the heart, this is how they describe it. The crisp S1 is at the base, S2 is louder than with a S1 with physiologic splitting of A2 greater than P2, and the apex S1 is louder than S2. There are no murmurs or extra hard sounds. For others, S1 and S2 are soft. S3 is present at the apex. There's a high pitch, harsh 2/6 holostolic form best heard at the apex radiating. This is an example of abnormal physical animation for the auscultation. Okay, so where are we now? We examine the patient supine with the bed elevated, then with the JBP, carotid pulse, we inspected, palpate precordium, all the intercostal space, and then we can let the patient shift to the left lateral decubitus if you can to assess the apical impulse and diameter, and you can use the bell of the stethoscope to listen at the apex. So this is used in a patient with a low pitch murmur, like in patient with a mitral stenosis. So fine elevated at 30 degrees angle. Listen at the second and right, left anticipate down to the left sternal body. So you have to listen to all the 6 listening areas with the diaphragm. Then, well, there's no order. You can start either from the apex or the base, but most of the time it starts on the apex. Okay, so and then try to appreciate in patients with right-sided murmurs. They usually are accentuated with the inspiration and then the maneuvers. Okay, so in patient, you have to use the this is the bell, and this is diaphragm. For some, there is no uh, uh, this is still a diaphragm. The bell is for low pitch sounds with the S3 third heart sound and fourth heart certain murmurs, which is the mitral stenosis. And for the most murmurs, you can use the diaphragm. can use in medium to high pitch sounds first and second heart. So you use diaphragm while pressing it firmly on the against the skin. Okay, so this is the order of auscultation. First S1, S2, and then check for the splitting of second heart sound. Okay, so where do you think you can appreciate the first heart sound? Okay, so remember again, the first heart sound is a closure of mitral and the tricuspid valve. So which is a higher pressure? Left side, right side? Left side is mitral valve. So normally the S1 is often but not always louder than S2 at the apex. As an example of abnormalities in X1, if it's accentuated, usually in patients with tachycardia, short PR interval. This is an example of a patient with a short PR interval, or a patient with high cardiac output states like in exercise, anemia, hyperthyroidism. Also in patient with early MS, while the mitral valve can still open wide. Diminished S1, this is for can be appreciated in patient with first degree heart block, patient with left bundle branch block, and patient with MI and early mitral valve closure. This is also decrease in patients with a congestive heart failure. It means that there is already significant involvement of the muscle, and it can have a diminished S1. Barring S1, this is due to complete heart block when there is a no connection between the atrium and ventricle, or a patient with a atrial fibrillation. Okay. Split S1 is occurs in patients with the when the west heart along the lower left sternal border, where the tricuspid component is often too faint to be heard, becomes audible. So usually these are seen in patients with right bundle branch lock, or patient with the PACs. Okay, for the base, are we at the base? For at the base, the S1 is softer than S2. Okay, for the split S2, listen for the splitting of the sound in the second. It can also be third intercostal space, and ask the patient to breathe quietly and then slightly more deeply than normal. So you have to check if it splits into two components. You know how the breathe split, timing of split. Okay, so physiologic splitting occurs during the inspiration. That's the most important. There's a physiologic splitting during inspiration. Okay, just accentuated during the inspiration, and this appears during expiration. And for the pathologic splitting, it can be wide or physiologic splitting. So for patients with the is due to delayed closure of pulmonic valve, which can be present in patients with pulmonic stenosis and right bundle branch block. For fixed splitting, number one example in here is the atrial septal defect. And for the paradoxical splitting, or reverse splitting, instead of splitting during inspiration, what happens there is splitting during expiration. Okay, so this is commonly in patients with left bundle branch block. Okay, how about the sounds of A2 and P2? Can be either increase or decrease or absent. Okay, for the A2 could increase intensity, can be present in patient with hypertension, while pulmonic component can be have increased intensity or equal or louder than A2 if you suspect pulmonary hypertension or presence of the atrial septal defect. If patient see decrease of absence, most of the time it's secondary to calcification of a stenosis. So this example is the aortic stenosis, and for pulmonic is the presence of pulmonic stenosis. So this can be appreciated at the second intercostal phase, left parasternal line. Now, what next is for the extra sounds in the systole, such as the ejection clicks and systolic clicks, and then note location, timing, intensity, pitch, and variation of respiration. So ejection sounds, systolic ejection sounds. The early ejection sounds means after the first heart sound, there's a sound. Coincident with sudden pathologic halting of the aortic and pulmonic valve. So most of the time, this is associated with a congenital problem. Okay, or like congenital aortic stenosis, bicuspid aortic valve. Systolic click. This is usually associated with mitral valve prolapse, and it's followed by late systolic murmur. This is the prolapse of mitral valve, which produces the systolic click. Okay, injection click here on the right second intercostal space. It can be a patient with aortic ejection sound. So either congenital stenosis or bicuspid aortic valve. So this is the ejection click because of the valve, and then followed with a murmur. And a patient with a pulmonic ejection sound, this is lesser, the second, third left intercostal space usually extends up to the murmur, extends up to P2, but same thing. No, there is a pulmonic ejection sound. So there is a patient with pulmonary stenosis or patient with pulmonary hypertension. Okay, how about patient with a mitral valve prolapse? There's the systolic click, but this is usually to abnormal systolic ballooning of the mitral valve into the left atrium related to elongated chordae tendineae. So usually they have either mid to late systolic murmur. Okay, so as you can see, it can be influenced by change of position. So we'll discuss it. It's a ballooning of the valve towards the left atrium. Sometimes these are already associated, like what you call mitral regurgitations. Some can have mild, moderate, severe. So usually in severe type, you need to be operated. But mild, you can have start medication, just start medication. Okay, so we're finished with the extra sounds in systole. Now it's the extra sounds for the diastole, such as S3, S4, and the opening snap. Okay, so start first with the S3. This is the third heart sound. It sounds like 4, it sounds like opening snap occurs very early and diastolic because of abrupt deceleration during the opening of the stenotic mitral valve. So it is best heard just medial to the apex and along the lower left sternal border. So if loud, the OS can radiate to the apex and to the pulmonic area. It is heard better with the diaphragm, so it's a high pitched sound. Opening sounds like okay. So how about for the S3? So the S3, as I have discussed to you before, it can be normal, physiologic, and be in children, young adults, up to 35 to 40. But if you able to appreciate S3 more than 40 years old, usually it's pathologic. Secondary to increase filling pressure and abrupt deceleration flow across the mitral valve. So prime example of S3 is because of dilated cardiomyopathy or congestive heart failures, ventricular volume overload. There can also be a right-sided S3, which is appreciated at the left lower sternal border. Okay. S3. About the S4, where do you think you can appreciate the S4? Oh, same thing, the mitral valve area. I can pour just before the S1. Okay, most common cause, as already mentioned before, hypertensive heart disease, aortic stenosis, ischemic, and hypertrophic cardiomyopathy. There is also right-sided S4, which is heard along the lower left sternal border or below the xiphoid area. Okay, let's move to identification of the systolic and diastolic murmurs. This is a full description of murmur: medium pitch, grade 3/6, flowing, crescendo, diastolic murmur, best heard in 4 intercostal space, left parasternal line with radiation to the apex. It is best heard when the patient is sitting or leaning forward with breath held after exhalation. This is a typical example in a patient with aortic regurgitation. So, start first with the medium pitch. How do you distinguish it from the high pitch, medium pitch, and low pitch? The prime example of low pitch murmur is in patient with a mitral stenosis. Most of the murmurs of is medium to high pitch murmur. So if it's low pitch, you have to use what part of the stethoscope? The bell. And for the medium and high pitch, you can use the diaphragm. Okay. Next is the grading. Patient's grading at grade 3/6. If it is grade 1, it's very faint. You have to tune in. Grade 2, it's quiet, but heard immediately after replacing the stethoscope. And 3, it's 3M, moderate, loud. 4, 4-letter word. And there's a palpable trill. Okay. 5th, grade 5, it's 5, very loud with trill, but the stethoscope partly off the chest. And grade 6 may be heard entirely off the chest. In 1, 2, 3, 4, 5, 6. So remember this one. There is a palpable trill starting for the 4, 5, 6. Okay, so 3. What is 3/6? It's a moderately loud murmur. So what is the grade 3/6? It's a moderately loud murmur. Next will be the blowing. What is blowing? Blowing kind of murmur. Blowing. This refers to the quality of murmur. No, can be harsh, blowing, rumbling, musical, humming or roaring, scratchy, or machinery-like. And these are the examples of it. And then crescendo murmur. This refers to the shape of the murmur. If it's crescendo, the murmur goes louder. If it's the crescendo, it grows softer. If it is there is a increase and decrease, this is a crescendo, the crescendo murmur. If it is the same intensity all throughout, you have plateau murmur. It's commonly is patient with the holostolic murmur. Okay, for the diastolic, wait lang. Okay, next for the crescendo is the diastolic murmur. So diastolic refers to timing of the murmur. So in order to not forget, just remember this one. Systole is during the time the ventricle contracts. Diastole is during the time the ventricle relaxes. Okay. You can see here during the contraction of the ventricle, this is the blood goes to the from left ventricle will go to the aorta via the aortic valve. For the right ventricle, blood goes towards the pulmonary artery via the pulmonic valve. There is a constriction on those vessels. This will produce a murmur. Hence the aortic stenosis and pulmonic stenosis. Okay, this is a systolic murmur. But in patient with normally the blood should go to the aorta and the atrioventricular valves are closed. This one, mitral valve is closed. For the right side, normally during contraction, blood should go pulmonary artery while the tricuspid valve is closed. If there is a defect problem on the mitral valve, the blood from LV goes back to the left atrium, causing the mitral regurgitation. If the patient has a problem with the tricuspid valve, during the ventricular contraction, the blood will go back to the right atrium. So that's why there is mitral regurgitation and tricuspid regurgitation. Mitral valve prolapse is of certain patients, mitral regurgitation. AST, additional BST, and hypertrophic cardiomyopathy. For diastolic murmur, just I might remember this one during the diastole. Okay, the atrioventricular valves, the aortic valve is closed because what valve is open during the filling phase is the mitral valve, so that the left atrial volume, left atrial blood will go to the left ventricle, and the blood from the right atrium will go to the right ventricle during the time that the ventricle is relaxed. Okay, so the aortic and pulmonic valve are closed. If there is a problem during the problem of filling, there's a problem in mitral valve, like there's a constriction, it will produce a murmur. Call it the mitral stenosis. If there is a restriction of flow from the right atrium going to the right ventricle, it can produce a diastolic murmur, which is the tricuspid stenosis. Okay, so if there is a problem in the aortic valve, meaning during the diastole it should normally close, there is lesion, and that happens, there is a backflow of blood from the aorta going back to the LP. This is aortic regurgitation. And for the right side, there is a problem here. Normally it should be closed during the diastole. No, there's a problem like vegetations or lesions. Then the blood goes back from aorta, from the pulmonary trunk, goes back to the right ventricle, causing the pulmonic regurgitation. No, so other examples, the ostensive murmur. Continuous murmur is when it occurs both in systole and diastole. And the classic example of this is the PDA, which we already discussed. PDA stands as a double two meaning. P for pulmonary artery, DA for our descending aorta. Okay, so let's start with the systolic murmurs. It may indicate a valvular disease but may occur even when the heart is entirely normal. It's systolic upon related to blood flow across the semilunar valves, aortic and pulmonic. Innocent murmur. This is due to turbulent blood flow from LV to aorta, common in children and young adults. And physiologic because of increase in blood flow, anemia, pregnancy, fever, hyperthyroidism. Okay, so the usual location is the second to fourth interspace, sometimes between sternal border and the apex. Ratio minimal, grade 1 or 2, possible soft to medium with the variable. So for the pathologic murmurs, as you can see, it's the shape, crescendo and decrescendo kind of murmur. So aortic stenosis, there's obstruction of flow during the systole, either by bicuspid valve or by rheumatic heart disease, can produce murmur. And the S2, which is component of aortic valve and pulmonic. Since there is a problem on the valve, there can be a decreased S2. Patient with hypertrophic cardiomyopathy, there is a thickened ventricular septum during systole, or in patient with pulmonic stenosis, just like a right-sided counterpart of the aortic stenosis, but this is usually associated with a junction click. Pansystolic murmur, on the other hand, is of course there is a holostolic all throughout of the systole. Okay, prime example here is the left, the mitral regurgitation, tricuspid regurgitation, or in patient with a ventricular septal defect. Okay, so the BST, MRDR. For the diastolic murmur, remember again, when the heart relaxes, the blood, what valve should be open? The mitral valve, but in patient with the aortic regurgitation, there's abnormal blood flow from aorta to the LP. So it leaks backward. Patient with the aortic regurgitation can have a crescendo type of murmur. For mitral stenosis, there is a narrowed mitral valve. It is followed by opening snap, decrescendo, then crescendo type kind of murmur. Looks like letter U. Say missed U. Okay, for the cardiovascular sounds with the both systolic and diastolic components, there is a venous hum, which is above the medial third of the clavicles. Best heard when the patient is in sitting position. Pericardial friction rub, and then the patent ductus arteriosus. So you can uh, usually the venous hum is humming or roaring character. For friction rub, they usually scratchy, scraping, grating. But for the PDA, usually the harsh or machinery like, and best appreciated at the left second intercostal space. No? So remember again that the second intercostal space is the site for the pulmonary artery, which is uh, there's a connection of pulmonary artery to descending aorta. Okay, we already finished with the timing of murmur. So next is the stolic murmur, best heard in the fourth left interspace, left parasternal line. So this refers to the location of maximal intensity. So aortic area, pulmonic area. This is the tricuspid area, and this is the mitral valve area. But you have to remember, sometimes you can also appreciate aortic sounds here, pulmonic sound here, and tricuspid sound here, and mitral sound here. So you need to listen carefully to the murmur. Okay, radiation. This is the radiation murmurs. Can range. If the patient with aortic stenosis, you have radiation at the carotids. So usually it can be auscultated at the lower part of the neck, or it radiates to the left third intercostal space for AR. So we have to determine if there is a radiation of murmur. Okay. Next is, it is best heard when patient is sitting and leaning forward with breath held after exhalation. What is this? This is response to the maneuver. So in patient with aortic regurgitation, best position is you have to let the patient sit up, leaning forward. So and using the diaphragm, because it's a high pitched murmur, and you can appreciate the presence better, the aortic regurgitation murmur. In patient with a mitral stenosis, you to advise the patient to lie on the left lateral decubitus position and use the bell, because it's a low pitch sound. Another maneuver that you can do is this one. Let the patient squat and stand. You standing position and squatting position. Squatting is almost the same with the Valsalva maneuver. So there is an effect on the mitral valve prolapse, hypertrophic cardiomyopathy. As you can see, during squatting, there is a increased volume on the left ventricle. So there is a increased blood on the left ventricle. So there will be a delay closure, delay appearance of the click. While in sitting position, there is a a smaller capacity of the LP, so there is closure of click to the first heart sound. This is in reverse to patient with the aortic stenosis. We will proceed to the peripheral vascular system. This is the common concerning symptoms: abdominal flank or back pain, or pain and weakness in the arms, claudication, cold, numbness, pallor legs, hair loss. So there are vascular disorders that can cause pain on the lower extremities. It includes the PAD, acute arterial occlusion, or patient with a Raynaud's phenomenon. Okay, venous disorders can also manifest with pain, which includes superficial phlebitis, DVT, and deep venous insufficiency. So as superficial vein thrombosis, deep vein thrombosis, there's already a thrombose. Okay, another cause of pain is the Verger's disease, compartment syndrome, and the patient with acute lymphangitis. There's a mimics, cellulitis, and nodosum. So let's focus on peripheral arterial disease. As you can see, it refers to stenotic, means there's a almost occlusion of the artery, or aneurysmal, or sometimes occlusive. It means there's already significant occlusion on the lower extremities. That's why it's called a peripheral arterial occlusive disease. But even this one, aneurysm, is still considered as a part of peripheral arterial disease. Okay, so you can have abdominal flank back pain. Do you think the patient peripheral arterial disease can have this one? Yes. Patient can also have pain, weakness arms, legs, intermittent claudication. This can be PAD, pallor, swelling. No. Color change. No. Swelling with redness. No, it's not big. This is these are the warning signs of peripheral arterial diseases. Any poorly healing, non-healing wounds on the legs, feet. Okay. So actually, the symptoms location suggest the site of arterial ischemia, like this one in the buttocks or hip area. Think of the aortoiliac artery. There is a erectile dysfunction. Probably that's all already affecting the iliac dental artery. At the thigh, the common femoral or aortic iliac, upper calf, superficial femoral artery. And for the lower calf, popliteal, foot, tibial, and peroneal artery. Okay. So for the ischemic changes, can have a blanching followed by cyanosis, then rubor with cold exposure and remarring. So this is typical in Raynaud's phenomenon. Okay. For the edema, these are the causes: pitting edema, secondary to heart failure, nephrotic syndrome, cirrhosis, or it can be due to chronic venous insufficiency and lymphedema. Okay. So how do you check the problem in the lower extremities or the upper extremities? So for the arms, you check the size. Now this one is obviously asymmetrical, and there is enlarged left upper extremity, and this is can be secondary to axillary node dissection and right? Radiation therapy. Usually it is done in patient with a breast CA. So they include the lymph node on the removal. Okay, so skin color, this visible venous collateral discoloration. This is suggestive of upper extremity deep vein thrombosis. Okay, so next is what? The radial pulse and brachial pulse. Okay, so before you proceed to that, the recommended grading of pulses is 3 plus, should be bounding. Normally it should be 2 plus, brisk for the expected. 1 plus diminished, 0 is absent or unable to palpate. Okay, so if you are unable to palpate, you can put 0. Okay, so brachial artery, radial artery, and ulnar arteries. Okay, so for brachial, so palpate for the brachial pulse. Just let the patient flex the elbow. It is located just medial to the biceps tendon at the antecubital crest and can be palpated at the groove between the biceps and the triceps muscles. For the next is the radial artery. Okay, the radial artery, this is how you palpate using the pulse of your fingers on the flexor surface of the lateral wrist. So sometimes you can partially flex and can help you localize the pulse and compare it to the other hand. This is important for taking the arterial blood gas analysis. And for patients with Raynaud's disease, they say that the wrist pulse are typically normal, but spasm of more distal cause episodes of that demarcated pallor. Okay, so for the ulnar artery, this is done by pressing deeply on the flexor surface of the medial part of the wrist. Now, as you know, that's the other flow, that the other ulnar is on the other side of the radial artery. So there is a dual flow to the hands. No? So if you want to know the patency of the either ulnar or radial artery, you should perform the Allen's test. So you advise the patient to do this one is for the test of the radial artery. This one is for the ulnar artery. Okay, for the radial artery, you can palms up, tight fist, and then you compress both the radial and ulnar artery. Then you open hand, so it should appear pale, and then after that you release the radial artery. Then there should be a flashing within about 3 to 5 seconds. Now for this other one, if there this one, you can release the ulnar artery and check for the flashing. Okay, usually if there is a palmar flashing, there is Allen test negative. But if there is a pallor, no, this is Allen test positive. Okay, so it means there is already problem in that area. Okay, ulnar radial. Okay, for the Berger's disease, they have absent or diminished risk, or which can occur in acute embolic occlusion or in Berger's disease. So next is we need to check the epitrochlear lymph nodes, which can be located here, or possible presence of cellulitis or possible lymph edema. Okay, next is the abdomen, thoracic aorta, iliac artery, superior mesenteric, inferior mesenteric artery. These are important branches of the abdominal area. So where can you appreciate the pulsation of abdominal aorta? It's actually in this place. You can appreciate the abdominal aorta at the epigastric areas. You can briefly auscultate in these areas: renal artery, iliac artery, femoral artery. If there is obstruction or murmur here, you consider it a peripheral arterial disease? Yes. Okay, and then you can palpate, estimate the width of the abdominal aorta. So you can measure the aortic width between 2 fingers. If it is more than 3 centimeters in diameter, this is suggestive of abdominal aortic aneurysm, the triple A. Next is you palpate for superficial lymph nodes. So this abdominal examination. Okay, so abdominal. Next will be the legs. Okay, legs, size, symmetry, and skin color. Okay, SSS. Okay, obviously the size is bigger on the left. This is suggestive of deep vein thrombosis. In the calf area, which is bigger, this one, say if it is unilateral swelling, measure the calf 10 centimeter below the tibial tuberosity. If it is there asymmetry of more than 3 centimeter, it is increases likelihood of DVT. Okay, or it can be also lymphedema. This is bilateral edema. The other one is unilateral edema or ankle swelling. Or this one is bilateral edema. Most of the time, it can be due to heart failure, cirrhosis, nephrotic syndrome, or if there's a venous distension like this, the edema can be suggestive of venous in origin. Okay, so what is the problem here? What's done, right or left? Okay, you can see there is a cyanosis on the right lower extremity. Okay, so since this is one of the signs of acute ischemia, you see in here, initially the foot can be pale, so it's part of a symptom in patient with acute ischemia. But that's the uh, early part of problem acute ischemia. But later on can be cyanosis, mottling, and then there's fixed mottling and cyanosis. Sometimes reversible mottling. If there is a local swelling, redness, warmth, and a subcutaneous cord, this signals superficial thrombophlebitis, which is an emerging risk factor for deep vein thrombosis. Okay, so how about the skin color? Okay, you can compare patients with the chronic arterial insufficiency. They can have atrophic changes, means there can be thin, shiny atrophic skin with the loss of hair over the foot, toes. The nails are thickened and ridged. So if there is an ulceration, it involves toes or points of trauma on feet. Okay, so usually the color is pale and or dusky red on dependency. For chronic venous insufficiency, they can be brown, or there can be associated stasis dermatitis, thickening of skin, or narrowing of leg as scarring develops. Okay. Chronic venous insufficiency can be brownish, say thickened or brownish skin. It can be due to advanced venous insufficiency. Okay, for arterial insufficiency, can have this necrotic areas. The usage is dry gangrene. Okay, neuropathic ulcers. You have to distinguish it. This is due to diabetic neuropathy. Okay, for the patient with the chronic venous insufficiency, usually it's over the medial and sometimes lateral malleolus. It can be a small painful granulation tissues and presence of fibrine. Okay, so you see the borders are irregularly flat and slightly deep. Okay, so that is for the chronic venous insufficiency. Okay, so size, symmetry, skin color. Next is the femoral artery. Okay, so where's the femoral artery? Yeah. Okay, so you can palpate it just below the inguinal ligament, about midway between the anterior superior iliac spine and symphysis pubis, and deep abdominal palpation. Uh, you can use the two hands on top of other obese patients. Okay, if the femoral pulse is absent, likely the patient is a peripheral arterial disease. So the occlusion can be where? The can be here, or it can be here, the iliac artery. So they can have a postural color changes. If you change the posture, there will be a change in color. Okay, if there is exaggerated widened femoral pulse, this is suggestive of femoral aneurysm. And the next artery is the popliteal artery. Patient's knee should be somewhat flexed, and it is appreciated at the popliteal fossa, but sometimes it's difficult. Yet you can do this one. You can let the patient lie on prone position and fold the patient's knee to about 90 degrees. Okay. So exaggerated, same with femoral artery aneurysm, you can have a popliteal artery aneurysm. The atherosclerosis most commonly obstruct arteries in the thigh area. This is the thigh area. So femoral pulse is normal, but the popliteal pulse is decreased or absent. So most of the time, there's atherosclerosis on that part. So it's important that you need to examine also the popliteal artery if you highly consider the symptoms the patient is related to peripheral arterial disease. Next is the dorsalis pedis artery. Okay, so palpate the dorsum of the foot, just lateral to the extensor tendon. This is extensor tendon, rugator, but can be absent. You cannot feel a pulse for the dorsum of the foot more laterally. Okay, next is the posterior tibial pulse. In this area, slightly below the medial malleus of the ankle. Okay, so next is the already finished with the pulses. Next is you need to check for the presence of edema. It's a pitting edema, no? It can be to heart failure, cirrhosis, malnutrition. No, you can grade it as 1 plus, 2 plus, 3 plus. You can just press on this area. So referentials for pitting. No, usually if it's pitting, and that appears in it, but non-pitting can be caused by chronic lymphedema or mixed edema, so thyroid problem. And you can grade the edema based on the depth and uh, how long does it last. Okay, so already discussed this one, chronic venous insufficiency and lymph edema. So for the lymph edema, can initially soft and pitting and becomes indurated, hard and non, so it becomes markedly thickened. For the DVT, the location of edema suggests the point of occlusion. Okay, if it involves only the lower leg or ankle is swollen, probably this the iliofemoral veins. If the entire leg is swollen, okay, so If it is on the lower leg, it's only popliteal vein. Ankle is swollen. If the entire leg, you think of the iliofemoral vein. Okay, so this is the femoral vein. This is the great saphenous vein. This is the blood vessel harvested during bypass graft. Okay, so there's a pain. If there's a painful, pale, swollen leg, together with tenderness in groin area, so you can palpate for the femoral vein. This is just medial to the femoral artery. So we think of proximal vein thrombosis, and this one is for the great saphenous vein. If you consider deep vein thrombosis, you can do the hormone signs by making patient legs flex at the knee and relax and palpate for the calf. There is a tenderness or present support, you consider DBT. Okay, so hopefully at the end you can able to identify extremities are warm and without edema, no varicosities, stasis changes, calves supple and non-tender, all calves are 2+ and symmetric. That is normal. Extremities are pale below the mid-calf with notable hair loss. This is already suggestive of peripheral arterial disease. Rubor when legs are dependent, no? So highly peripheral arterial disease, but no edema ulceration. Bilateral femoral bruit, it means that the occlusion is on that part. So, but no abdominal bruit is heard. So, but you have to check also the iliac artery for auscultate for the iliac artery, and brachial and radial pulses 2+, femoral popliteal, sides pedis, posterior tibial pulses are 1+. Okay. Thank you very much for listening. That ends my lecture for cardiovascular and peripheral vascular system. Thank you.